Hello, everyone. We're going to get started in a minute or so. Just give people a chance to log on. So, good morning, good afternoon, good evening, everyone. My name is Nicole Petrowski, and I'm a statistics and monitoring specialist in the data and analytics section of UNICEF headquarters in New York. Before we get started, just a reminder that we are offering simultaneous interpretation today in Arabic, French, and Spanish, and you can access these different language channels using the globe button at the bottom of your screen. It is my great pleasure to welcome you to this webinar as part of the joint UNICEF RISE Institute webinar series called From Fragmentation to a Unity of Effort for Early Childhood Development, which began in 2022. This is the sixth webinar in this series, which aims to inform and support data specialists and child development leaders to identify their data needs and build capacity to plan the development of national multisectoral ECD monitoring, evaluation, and reporting systems that integrate and use the Sustainable Development Goals indicators as well as regional and national indicators. In this webinar, we will unpack the role of developmental screening tools in providing care and services to young children and their families, and their importance as a central component of national data collection systems. Now it is my great pleasure to introduce our colleague, Emily Vargas-Barron, who is the director of the RISE Institute and will be introducing the other panelists for today. Emily, over to you.
Thank you, Nicole. Dr. Holly Hicks-Small is a leading specialist in early childhood intervention and developmental screening in the world. She is an associate professor at Portland State University in the United States in the state of Oregon, where she directs an early childhood intervention graduate program. In addition to preparing licensed early childhood intervention providers, Holly conducts research and contributes to the field through training and technical support. Holly has worked on ECI systems building in many Central and Eastern European countries and in Myanmar, where she served as a Fulbright Scholar. She has trained and consulted on ECD and ECI in over 16 countries for nearly 2 decades. Our second presenter will be my favorite pediatrician, and you will see why. Dr. Kevin Marks is a pediatrician. He also has a PhD in public health, and he has worked for many years as a full-time general pediatrician at the Peace Health Medical Group in Eugene, Oregon in the United States. However, he is currently working as a doctor at Odense University Hospital in Denmark, where he resides. His clinical research and leadership activities have focused on developmental and socio-emotional screening in children 0 to 5 years of age. We couldn't be better than that for our topic. And secondly, he also looks at psychosocial aspects of children and adolescents with type 1 diabetes. He has conducted extensive research on developmental screening, and we will benefit from his knowledge today. Now, Holly, would you like to make our first presentation?
Thanks so much, Emily. And thank you everyone for being with us today. I will focus on standardized broadband developmental screening tools in my talk. And these tools cover multiple domains of development, such as motor, communication, adaptive skills. And they're usually completed by the child's parent or guardian, either independently or with support from someone with training. Screening tools must have sufficient evidence of reliability, validity, and have psychometrically sound cutoffs based on data from a normative sample. And this normative sample is the reference population. But today I will focus on our need for sufficient evidence to justify the use of a tool. Next slide. So on this slide, I hope to show that screening can be used across systems that interact with infants and young children. The universal implementation of screening tools at set age intervals provides important information to health professionals. as they monitor a child's development. The tool may also be completed at a clinic or even on a home visit. But educators can also use these tools. Very often, educators will use a screening tool at the start of an early childhood program when a child enrolls, but they might also use it in the middle and at the end of the year to understand how groups of children are doing. And these sectors can work together. So for example, when a child becomes involved with child protection, screening may be completed in collaboration with the child's physician and resource parents and the child protection team. Health home visiting teams may also carry out initial screening and then use that screening to support the child's transition to education by sharing the results through a joint family conference. And these are actual approaches used by countries. Next slide. Next slide. Thank you. So children whose development is significantly different from age expectations are usually identified, but those with mild delays are often undetected without a standardized screening tool. And previous research has demonstrated how personal bias can prevent timely and accurate decisions. In the context of screening, all children without known disabilities should be screened. So we need to be using a universal screening approach. And when used over time, screening is part of ongoing monitoring by not only health professionals, but other individuals providing a child or family service. Next slide. But today you're here because you're interested in bigger data sets. So this presentation is really for people interested in those large data sets. And if sectors in a country can coordinate on screening and share data, it can be used to understand trends and make resource and policy decisions. So for example, we can aggregate and compare results by geographic location, available services, or a demographic characteristic. We can look at issues of disproportionality where there may be a higher prevalence of child delay in one group compared to another group. And we need evidence that the tool is functioning as intended to feel confident in our interpretation and decision-making. Next slide. So these are the most common tool considerations. People generally want to know how long is this tool going to take to complete and how many items must be answered. They want to know who can complete the tool and if any materials are needed. And generally, we ask about cost of purchasing the tool, if there is an available translation, and adaptation and training requirements are also of interest. And while people ask about the domains covered, like communication and physical, they don't always ask about the coverage of the domains. And the same is true for validity and reliability and the process for obtaining permission to adapt an existing tool. And so today I want to share with you why we need to look more closely at those factors. Next slide. I recommend using a participatory approach to tool selection or development. Include the intended beneficiaries and people with disabilities, and include underrepresented and minoritized groups. Start by defining your purpose. Why do you need this developmental screening data? And then gather the available evidence. And if there's an absence of evidence, that's also important to consider. And look for biased evidence. Then select your criteria. What is good enough evidence and why? And intentionally confront value-based decisions and look for the identities of those pushing one value over another value and examine the trade-offs. And look at the feasibility of what this team proposes, both short-term and long-term. Next slide. Evidence is information, and that information impacts our decisions. And we really need to question that available evidence. When we're pushed to select or develop a screening tool quickly, we might sacrifice steps that would help us make more informed and less biased decisions. Next slide. So at its core, tool selection or creation is measurement work, and validity is central to this work, but unfortunately, it really remains misunderstood by many people who are actively engaged in the work or who are evaluating the work done by others. Next slide. So I really want you to remember this slide. A measure is neither valid or invalid. It's the accumulation of evidence that is used to justify the tool's use. And this evidence is specific to the context. Evidence does not travel to new lands. I cannot collect evidence in one country and say that it automatically applies to all countries. Next slide. So in published literature, a unified theory of validity is now recommended. And this begins with stating the purpose of the tool, and then we collect information on different aspects of validity. This is an iterative process as we gain additional data over time. Next slide. So we have many forms of validity, and content validity has to do with the representation of the construct of interest. Where did the content come from? Are the items from other tools, and what is known about those tools? And rather than looking only at translation, we really need to understand if an item is relevant and understood. Does the item function as intended? If the individuals involved in item selection or development are not representative of the population, including underrepresented groups, the tool may not work as intended. And individuals representing multiple disciplines should also be included in the process. Next slide. We also want to look at response process. Individuals with specific characteristics may respond differently to items based on their education and lived experiences. For example, a community may believe they will gain more access to resources if their child's development is delayed. Another community may be worried that they will be reported to child protection. A physician in private practice may worry she will lose patients if she asks a parent to complete a screening tool and it shows a delay. In some contexts, observations may be more appropriate than asking the child or adult a direct question. And by collecting different forms of evidence, we can identify important adaptations, such as adding visuals or creating an oral version to improve the tool. And these are all real examples from my work in the field in different countries. Next slide. So internal structure is something we're all pretty familiar with and look at. And it is important to look at how the items relate to each other and the domain or the total score of a screening tool. When an item has poor reliability or item fit statistic, we need to look at why rather than immediately eliminating the item. We can use other statistical techniques to examine how well the tool covers a construct. In the published literature, less attention has been paid to the reference sample, and many studies have very small samples or samples that don't represent the population where the tool will be used. And data quality may also be questionable when data collectors have not been trained or supervised. Studies that are published but don't provide enough detail to fully understand what took place need to be cautiously interpreted. Published literature has shown physicians do not detect mild delays. So when you have a study that only uses physician impression as the gold standard, to compare the results of the screening tool, we should interpret those findings with caution. Next slide. We can also collect evidence on the relation to other variables. So if there are assessment tools with sufficient validity evidence in a country, we can look at the relationship between the screening tool and that measure. We can also look at associated variables with developmental delay that are known for that country. So again, it's the total body of accumulated evidence that supports the validity argument. Next slide. And we want to also look at the consequences. Our words and our actions have immediate consequences for families and children. So we want to be using strengths-based and family-centered approaches to screening. And there are also long-term implications. If we use a brief tool and that tool does not select children with mild delays as needing further evaluation, this can impact the child's development and family life. If the tool doesn't pick up on a delay, a trained professional using the tool may feel confused and reluctant to use the tool in the future. And the professional and the parent may be angry once the delay is finally identified. Failure to detect delays can place a financial burden on health, education, and social support systems. What began as a mild delay may become more pronounced and involve multiple areas of development over time. Next slide. And we want to look at feasibility. All aspects of the tool will need to be considered to determine if it's feasible for implementation. But on this slide, I will only highlight the maintenance piece. And what I mean here is that once you select or create a tool, your work isn't finished. Research on the tool should be ongoing, and a tool should be updated at least every 10 years. And there are costs associated with this maintenance and other feasibility factors. So a published tool may come with initial cost, but required costs over time may be more limited, while a tool in the public domain may be free initially, but charge a lot for training and for ongoing maintenance or have no maintenance plan in place. When looking at a tool, look at the total materials available. Is there a user's guide? Are there documents to support new users from different sectors? And have the psychometrics been fully reported? Next slide. So I will close with this, a couple slides on misconceptions and recommendations. So again, no single study makes a tool valid. And just because a tool is created and adapted for one low and middle income country does not mean it will work across all low and middle income countries. A single tool across a few countries does not mean the tool is ready for use in any country. And one tool is probably not sufficient for a heterogeneous country without further adaptation. Translation alone is just not enough. Recommended practices for translation need to be followed, but we also need, again, to collect more evidence. Homegrown tools might be a good option, but an argument must be made. We know time is a barrier, but there are consequences for using a limited number of items. Next slide. Parents gain a lot when screening is done well. They have the right to understand their child's development. And published literature supports parent report. Tools that use easily observed skills and items parents can see and understand improve parent report. And trained individuals from different sectors can implement developmental screening. Screening supports conversation and decision-making. It identifies area of strength, not just need. And screening tools may have items that ask about parent concerns, recent illness, hearing or vision concerns, and life events to gain a more holistic picture of a child's development. Screening tools can make conversations with parents more efficient. Results can be used to highlight strengths and again, focus on areas of concern, but efficiently. Training must cover not only how to score a tool, but also how to interpret results and how to communicate and jointly make decisions with parents. My last slide is just a few recommendations, and I hope I'm not over on time. So for any tool, please look carefully at the entire evidence available. This includes looking at the quality of any published articles, the journal quality, whether this was a paid publication and the year of publication, and look at the conflict of interest that might be present. Who published the study, who collected the data, who analyzed the data, and who funded the study or tool development. Those providing training should have experience working directly with families and children. And the language used in the training and all materials should align with recommended practices that support a strengths-based and family-centered approach. And finally, look at your short and long-term investment. The great news and a takeaway from this is that you can find others who can support you in your work. Multiple forms of evidence can be collected simultaneously to generate an argument for the tool used and for you to ultimately feel more confident when you make statements about the national level data that you analyze. Thank you so much for listening to my presentation. If you have any questions, I hope that you will get in touch.
Thank you very much, Holly, for that comprehensive and very useful presentation. Dr. Marks?
Hi, so my name is Kevin Marks. My presentation has 4 parts. First part, team-based implementation. It's going to be very practical. Second part, why screening and monitoring go together. In the US, we refer to it as surveillance. I prefer the term monitoring. Number 3, how to interpret a screening tool and discuss next steps with parents. I'm going to provide evidence and experience. And number 4, quality improvement and why it's a never-ending process. So next slide. Okay, so first point is implementation matters. It's not just about the tools you choose, it's about how you use them. And so broadband developmental screening tools are what we're talking about here, because our purpose is to try and figure out if a child probably has a developmental delay in one of many domains or probably does not. For our purpose of detecting a wide range of developmental conditions, we also may need some supplementary questionnaires to help us identify risk factors or maybe zone in on one particular domain, such as social emotional skills or autism. Next slide. Next slide. Okay, so again, the purpose. I want to emphasize this. The purpose is not only to categorize children into low, moderate, and high risk groups. It's also about having a better conversation with parents. It's about building relationships over time. And if the child is having these milestones are coming early, whether they're emerging or they're mastered or they're even coming a little late, we want to celebrate these milestones. Please think about the song Celebration by Kool and the Gang when you're doing screening, because that's what I want you to think about. Be strength-based. Next slide. Okay, so next step, you have to map out the process. You have to assemble your team. Everybody has to play a role and have a job and do it well. When you map out the process, it can be done in a medical setting or an early learning preschool setting, but map it out and make sure that everybody understands their purpose. Next slide. So I'm going to just give as an example the medical setting where I work. And so the first step is just scheduling an appointment. And so the person who is communicating with the parent to make that appointment is a member of our team. And so it's important to prepare the parent and make sure that they understand that developmental screening is an important part of the visit. And if they can, it would be fantastic if they could do this on an app or online a week before their scheduled visit. And it's very important to say this sentence: if you need any help filling out this questionnaire, please let us know, and then have a plan for how to address it if they do need help or they have a literacy problem. Next slide. Next slide. Thank you. So the next step is the parent has to complete the questionnaire. As Holly kind of alluded to, parent-completed developmental screening questionnaires do have many advantages. They cause the parents to reflect upon his or her child's skills in many different domains. I love the fact that they have to put down their phone and they may have to observe their child doing some specific milestones, just face to face. And it really promotes these serve and return parent-child interactions. And serve and return interactions is what neuroscientists tell us that helps the brain to grow better. So direct observable screening tools may have a role, but I like the ones that kind of involve the parents more. Next slide. So I want to emphasize that when doing screening, it should be done with fidelity, and there usually is a double checking process that should be done before it actually gets scored. If you do it online, a lot of this stuff is done automatically. But question to ask yourself as a medical provider is, who completed this screening tool? Was it the mother or the father or somebody who really knows his child well, or was it a foster parent who just started caring for this child in the last 1 week? Is there a literacy problem? Is it the correct age interval? Is it the most optimal language? Have all the screening questions been completed? Next slide. So with scoring, most of the time in the real world, it's done on paper and pen. And I'll say that for most of the good developmental screening tools, the scoring process is very straightforward. If you find yourself confused about how it should be scored and interpreted, and it's too complicated, that's a feasibility disadvantage. Now, if you do scoring online or with a tablet-based screening system that inputs into the electronic health record system or app-based screening, this is more optimal because then you get the best language for that parent, the correct age interval, and it automatically adjusts the age interval if you're looking at milestones for X preemies. It corrects for the adjusted age up until 2 years. Now, pre-visit automated screening maybe makes the process more accurate and reliable, but very importantly, in the real world, it has to sync with the electronic record system. This saves trees, slashes paperwork, and for physicians who are trying to track data over time, it produces better data that's easier to interpret and analyze. I also love that online screening programs can send parents developmental learning activities that will promote healthy developmental skills and make them more focused on these wonderful milestones. Next slide. So I want to address this. There are a lot of cynics out there. So there is a lot of evidence in favor of early intervention, specifically intensive early intervention, and it helps improve all these outcomes that you see on the screen. But next slide. Unfortunately, for developmental screening, I want to be transparent. There is a paucity of literature saying that there are longitudinal randomized controlled trials in periodically screened versus non-screened populations. However, next slide, that is not to say that the dots are not being connected. The evidence over the last 2 or 3 decades has really accrued over time. There is more and more evidence for developmental screening. And here's a good example. Effectiveness of developmental screening in an urban setting, published in Pediatrics 2013. Randomized controlled parallel group trial for medical practices. There were 3 screening arms, as I recall. One was you get a history, do a physical, and you make a decision. Another arm was screening, and you had no office support in the reception area. And then the third arm was screening with office support. So maybe with some toys to help the parents figure out if the child could do something, like a fine motor skill. And so what this randomized controlled trial found was that the two arms where there was screening, specifically in this study using the ages and stages questionnaire at 9, 18, and 30 months, and an autism-specific screening tool called the MCHAT at 18 and 24 months, that it improved outcomes because it identified delays earlier, and it led to earlier referrals to an early childhood intervention system, and it led to earlier delivery of services or completion of the early intervention referral and linkage. Next slide. Another study was done by myself and one of the co-presenters, Holly Hicks-Small. This study was conducted over a 1-year-long period. It involved 3 practices. It was a large number of patients, so 1,428 caregivers and children. It's important to say that those who were already identified as having developmental delay or receiving services were excluded from our study. The people who were involved with looking at the kids were 20 healthcare providers, 18 of which were board certified smart pediatricians who I used to work with. When they did their history and physical at 12 and 24 months, they came out of the exam room and they immediately had to fill out a form in this study. It was called the Pediatric Developmental Impression Form. And they had to check a box whether they thought the child was typical, questionable, or delayed. And if they thought the child was questionable or delayed, they had to say which developmental domain they had a concern about. And they were blind to the ASQ results. And it's very important to say that. So what this study found was that this screening tool in this study, the ages and stages questionnaire, led to a 5 to 6-fold increase in referrals at 12 months and a 2-fold increase at 24 months. All in all, referral rates increased by 224%. That was a big impact. And then in follow-up, we published another study. It was in pediatrics, and we found that there was some longitudinal quality improvement needed for the children who are born premature, and that pediatricians may want to lower their threshold for referring or screening those kids. Next slide. So I want to talk about monitoring. What is that? I want to make sure people understand what it is. So in the US, we call it surveillance, but again, I like monitoring. Number 1, elicit the parents' concerns and do it skillfully. Formulate the question correctly. Number 2 is gathering a developmental history or reviewing those age-specific milestones. Number 3, identify risk and protective factors. Number 4, it's your physical exam, growth charts, head-to-toe exam, and also paying attention to parent-child interactions. That's also very important. And number 5, when a pediatrician or a doctor is doing anticipatory guidance or trying to promote developmental well-being, and then you're listening to the parents' reactions to your advice about choking prevention or remembering to keep small batteries away from your child, you're kind of also gathering knowledge. And so also book reading, when you give the child a free book and you watch them hold the book and turn the pages and you watch how the mother or father responds to the child while they have a book. This is good information for monitoring. 6, documentation. This is an important part of monitoring. And then 7, there are many follow-up steps that come after screening, and I'll get to that later. So next slide. Screening and monitoring. This is a key point to my presentation, that these two things are better together. Here's some evidence. This study was published by Barger and colleagues in 2011, I believe, and it said that children who received developmental monitoring and screening together were significantly more likely to receive early childhood intervention services compared to those who only received monitoring, those who only received screening, or neither. Okay? And so you might ask, well, how did they measure whether they got screened or monitored? The answer is it was a national telephone survey of a very large number of US caregivers. The survey return rate was 51%. So is it the best? Are we absolutely sure that this is correct, that they were screened or monitored according to the parents' recall? Not really, but is this a good enough hint that screening and monitoring should be put together? Yes. And I'm going to provide more evidence. Next slide. So in our own study, remember that the pediatrician or nurse practitioner filled out this pediatric developmental impression form. And at 12 months, when a referral was generated based on history and physical, interestingly, 0% of the time it was for a family that was Hispanic. 0% of the time it was due to a concern about a fine motor delay or a personal social delay. Ask yourself, is that true? Is there something wrong with that? And then look at what happened with the ASQ referrals. At 12 months, 15% of the referrals were for families who are Hispanic, and there was a much more even distribution of developmental domain concerns. Another interesting thing I noticed was that the pediatrician or the nurse practitioner was a little bit more, a higher percentage of the referrals were for families who are low income or had in the US Medicaid insurance. Now, this actually might make sense because having a lower family income could be a risk factor when monitoring a family. Next slide. At 24 months, again, interesting patterns. I want to point out that this time at 24 months, 96% of the referrals from the pediatrician or nurse practitioner were for communication domain delays. 0% were for gross motor domain delays. Whereas with the 24-month version of the ASQ, 60% of the referrals were for communication delays. And then again, there was more even distribution with domain delays. So next slide. Thank you. So this is an interesting point. Without the ASQ screening, 58% of the children, which was 62 children and families, would not have been referred earlier to the early childhood intervention agency based on monitoring alone. Key point. Now, but when the pediatrician, mostly it was pediatricians, did do a referral, 92% of the time, the follow-up assessment agreed that this was a good referral. So when a pediatrician notices a problem, they're usually right. When the ASQ results generated a referral, then 63% of the time, the early childhood intervention agency agreed with the assessment. However, I want to say that I did a follow-up study and I looked at these ASQ referrals over time, and what I noticed is that again, there was a concern at the next visit or the next visit after that. And over time, I noticed that these kids who were referred with the ASQ at 12 or 24 months were eventually made eligible for services. So I came to realize that in the state of Oregon, they may have overly strict criteria for what constitutes a developmental delay. And I developed an opinion that maybe a higher percentage of these ASQ referrals should have been, given services earlier. Interesting point is also that when the pediatric developmental impression form and the ASQ concurred that there was a concern about development, there was 100% agreement with the follow-up assessment. Next slide. Thanks. Next slide. So another study, again, more evidence of the same cross-sectional design here, 95 children. They looked at screening. Again, they used the ages and stages questionnaire and monitoring at 9, 18, and 24 months in their large pediatric practice. And I'll get to the golden nugget. That is that 10 of the 15 children scoring in the referral zone for the screening tool were not identified by a U.S. pediatrician's monitoring skills alone. And remember, they've had a good training program before doing this. Next slide. This is more evidence. This time it's a systematic review published by Sheldrick and colleagues a while ago in pediatrics. So this looks at the ability of a pediatric healthcare providers to identify a developmental delay. They found 539 studies, 11 of them met inclusion criteria, and they found that a pediatric healthcare provider's monitoring skills has poor sensitivity. Sensitivity ranged in studies from 14 to 54%. That is not good. So don't have your gold standard assessment be, a pediatric, impression based on one visit. Now, pediatrics, their sensitivity was poor, but their specificity was actually pretty good. It was 69 to 100%. So when they identify a problem, they're usually right. There was an outlier study. With most systematic reviews, there's an outlier study. I've done 2 of them and noticed the same pattern. Next slide. Okay, so take home here, I just want to review. So number 1, what does screening do for you? It dramatically improves the detection of younger infants compared to the older toddlers. Number 2, it improves the detection of many different types of developmental domain delays. And I've noticed in my research that it's especially these personal, social, problem solving, and fine motor domain delays that good pediatricians and nurse practitioners tend to miss. Screening really helps to better detect the children with the milder delays. And here's something that I've noticed. It seems like these are the same kids who respond better to early childhood intervention services as compared to the child with a global severe delay. Point 4 is that screening compensates for a pediatric healthcare provider's poor sensitivity, and developmental monitoring helps to improve a screening tool's suboptimal specificity. So I really want to drive home this point that don't just do screening, also do monitoring. Next slide. So when interpreting screening results, ask yourself, have any of the screening test items been skipped or marked not yet? If yes, has the parent tried that task? Is there a teachable moment where I can maybe see if they can do this fine motor skill right here in the exam room? And then when you're looking at results, pay attention to patterns. For example, at 12 months, there's a monitoring zone or borderline results on communication and personal social skills. Maybe that child needs a follow-up visit, maybe at 15 months. Maybe you shouldn't wait until they're 18 or 24 months. You might want to make sure that child's not developing autism. Look at the patterns. Next slide. I want to talk about wait and see versus missed delays. This is pretty cool. A wait and see delay is when there's a questionable or delayed impression on that pediatric developmental impression form, but the ASQ recommended a referral. And then the follow-up assessment says there is a diagnosable delay or a sufficiently at-risk condition that requires careful monitoring, okay? And a missed delay is when the pediatrician or the nurse practitioner, after doing their history and physical, say, looks good to me. But then the ASQ picks up a concern, generates a referral, and the follow-up assessment shows that there is indeed a diagnosable delay or sufficiently at-risk condition. So this is interesting. In our study, we found that there were more missed than wait and see delays at both 12 and 24 months, and there were a higher percentage of missed delays at 12 months. Key point. Now, so then we looked at patient social demographic information, and that did not explain these patterns. Next slide. Thanks. So discussing next steps, I want to share just one quick study. It was a qualitative study. It involved focus groups with a lot of mothers. And what they found is that most mothers prefer a non-alarmist or sugar-coated approach to communication. However, there are a percentage of mothers, a smaller percentage, that actually prefer straight talking, where you just kind of say exactly what the screening tool is showing, or you might just say that there is a speech concern or delay. However, my 2 cents is that talk about the areas of strength first. Remember to celebrate those milestones. Think about Cool in the Gang and celebration. And then discuss the suspected challenges second. And I would refrain, for the most part, from using diagnostic labels because screening tools are not a diagnostic instrument. And be careful about using potentially harmful words like he passed or he failed the test. That doesn't feel right to me when I talk to parents. Be culturally appropriate and do not take a wait and see approach. Next slide. So when discussing next steps, you could do a perfect job, you could communicate great, but still a large percentage of families who have children with a developmental concern may not be connected and linked to these early childhood intervention services because there's just so much going on in their life. They have many other things that they're thinking about, and so it's hard to follow up. And so this particular study by Nelson and colleagues really points out the beauty of care coordination and how it can increase the number of children who get served. And this was a randomized trial. And they found that for children who are 1 to 3.5 years of age, that telephone-based developmental screening. And in this study, they used a different screening tool called the Parents Evaluation of Developmental Status, that plus care coordination appeared to be a pretty effective approach for increasing the number of children screened, referred, and receiving services. Next slide. Quality improvement. Let's say that your plan as a clinic is to make sure that screening doesn't lengthen the well visit because it can only be 15 to 20 minutes. Let's say that you want to make sure that it doesn't harm parents, be harmful to parent satisfaction or the delivery of your anticipatory guidance. And so then you do the pre-visit developmental screening, and then you study. And your study question here would be, how does the screening affect the length of the well visit in minutes and seconds? How does it affect parent satisfaction and the receipt of anticipatory guidance as measured by a survey? And then you execute your plan. Next slide. So that example, actually there's a study about this, and this is interesting. So after implementation of one particular screening tool called the PEDS, the visit length was not lengthened. It was actually shortened by 2 to 3 minutes in the second and third wave of implementation. So actually, screening can make the visit more effective. You spend less time gathering information about milestones or concerns, and you spend more time doing observation. In Danish, we say hygge, and basically just talking about next steps. So it can lead to a better conversation, okay? Now, after implementing the PEDS, a higher percentage of parents in this study reported that their healthcare provider talked about their concerns and they felt that their questions were answered. However, in this study, it needs to be said that they did not find a statistically significant change in parent satisfaction ratings or the parent reported receipt of anticipatory guidance. So what do? You do another PDSA cycle and you try and improve on that. Are you getting the picture? Next slide. Another example of quality improvement, plan. Our community or our country is very multilingual. We have many different languages in our community. It's mostly urban, and we have a very wide range of literacy levels in the parents. So our intervention here, our DO, is a computerized clinical decision support system. And the study question this time is, what percentage of kids in the critical window of 0 to 5 years are screened, monitored, referred, and linked to the early childhood intervention services pre and post implementation. Then you act, you execute the plan or intervention. Next slide. So there's another study that answers that PDSA question. So this was published by Carroll and colleagues in JAMA Pediatrics in 2014. I really enjoyed reading this study. It was about that computerized clinical decision support system and an automated developmental screening. And it, no surprise, it increased the percentage of kids who are screened at the intervals that are recommended where I come from in the United States, 9, 18, and 30 months. But what was interesting is that this intervention also improved developmental monitoring. So the people who are asking questions about the parents' concerns maybe got better at that. And there was also an improvement in monitoring skills at visits where there wasn't screening. And this intervention increased the number of children who are diagnosed as having a delay and referred to early childhood intervention services earlier. Next slide. So going back to Holly's point, you know, I talked a lot about medical settings. That's where I come from, but it needs to be said that in many low, middle, and high income countries, it may not be realistic to kind of twist the arms of doctors to, especially general practitioners who don't have that much pediatric training, to perform high quality developmental screening. And so it may be that you have to implement screening in a nurse home visit setting or a daycare or a preschool setting. But when you implement it, implementation matters. It has to be done well. Where I come from in Denmark right now, I've come to the conclusion that the general practitioners are probably not ready to do high quality developmental screening. And it may be the case that in a high income country like Denmark, it should be done at home visit settings, daycares, and preschools. Okay, just so it depends. Next slide. These last two slides are just kind of giving you a big picture look at the whole process. Many of these things are things that Holly already talked about. I talked about the importance of thinking about your purpose. I want to point out that in addition to what Holly said, think about your quality aims. When you're screening and when you're implementing screening, think about making it safe, effective, parent-centered, timely, efficient, and very importantly, equitable. Just because the parent doesn't speak the most common language, it's not a reason they can't get screened. You should not rob children and families of an opportunity to get these valuable early intervention services. We should increase capacity at a system-wide level in the big picture of the early childhood intervention system. And when we implement screening and monitoring, do it with plan, do, study, act cycles if you can. Next slide. Thank you. So remember, combined screening with monitoring before you come up with whether the child is in the high risk, moderate risk, or low risk group. The country where I used to work at, about 85% of the kids are going to fall in the low risk group. And then, you know, it's good to communicate with the early childhood intervention agency or program if you think this child is in a high risk or moderate risk group. And you should do two-way communication between these two entities with the parent's consent. Now, once they get into the early childhood intervention system, they're going to find that some kids are actually doing fine and they don't need services. There's a larger percentage of kids who need less intensive, less expensive, more focused, but very importantly, family-centered early childhood intervention services. And there'll be a smaller percentage at the top, the tippy top of that pyramid model, who need, they need the intensive, specialized, interdisciplinary, and family-centered early childhood intervention services to really get those better outcomes. Last slide. So take-home point to my presentation is simple. Please do not wait and see. Remember, waiting and seeing is for sunsets. It's not for detecting and addressing developmental and behavioral problems in children. Thank you.
Thank you very much, Dr. Marks, for your excellent presentation. We're kind of running out of time, and I was going to present on 8 steps for implementing national ECI systems for child developmental screening, tracking, monitoring, and planning. What I'm going to do is make an overview statement, which is that we have looked at the window that opens when we do developmental screening combined with pediatric monitoring. This window gives us an opportunity to gather data that can be used throughout our countries at national and subnational levels for budgetary planning, program planning, for anticipating needs in healthcare, for special healthcare, and anticipating needs for inclusive pre-primary and primary education. At a later point, I hope that I can present on these 8 steps that I have outlined, but I think that the most important thing is that you have had this wonderful opportunity to learn about research and program activities that have been conducted in a range of settings. We are also very aware that in countries throughout the world, there are varying levels of resources. Adaptations can be made to enable all countries to develop very good developmental screening and monitoring systems, and to link children and families to family-centered, highly individualized care and development services through early childhood intervention. This has been very successfully developed in the country of South Africa, where Claudine Storbeck and her large teams throughout South Africa have developed family-centered early childhood intervention activities, often under extremely resource-limited situations. We know it's possible. We have extensive experience in other settings to know that it is possible. And what we feel is that behind this lies a great gold mine of data that will be able to be mined to enable us to predict and manage services, to invest better, to ensure that children with disabilities, developmental delays, and varying types of at-risk situations to be well served, identified, and well served over time. So we thank you very much for attending this webinar, and we strongly want to thank UNICEF for being our partners in this activity, especially Nicole Petrovsky and Claudia Kappa. I would like to thank Holly Hicks Small for her superb presentation and Dr. Kevin Marks for his compelling and very important presentation. I'm sure that we all get joined together to wish you all a wonderful day ahead and an evening for some of you. Thank you for attending our webinar. We were delighted to be here with you. Bye-bye.
Thank you, everyone. And there will be a recording and PDF of the presentations today will be made available to everybody who registered for the webinar. So you will receive that. I know there were some questions about that in the chat. We also, unfortunately, did not have time to respond to questions, but we are taking note of all of the questions and we can ask the panelists to provide some written responses to these questions as part of the follow-up outreach email as well. Thank you very much.
Thank you.